Welcome back, medical students, to another explainer. I am so thrilled to have you here today because we are going to do a really high-yield, rapid, clinical ward-style review for diagnosing heart failure. When you're out there on your internal medicine or cardiology rotations, mastering this workup is, well, it's absolutely crucial. We're going to build a solid mental algorithm today, one you can literally use right at the patient's bedside.
So let's put ourselves right into that clinical mindset. You're on the wards, your pager goes off, and you're called to evaluate a high-risk patient who has just presented with acute dyspnea. They are gasping for air. The immediate question you have to ask yourself is it heart failure? Now sure, when classic signs and symptoms are screaming at you, making that diagnosis might seem relatively straightforward. But you always need to maintain a high index of suspicion, especially for your high-risk patients. You have to prove it, and you've got to figure out the specific underlying etiology.
Here's a quick look at our agenda for today. First, initial routine evaluation. Second, biomarkers in heart failure. Third, non-invasive cardiac imaging. And fourth, specialized and invasive testing.
Okay, let's dive into the step-by-step pathway. What's great is that this chronological algorithm mimics the exact sequence of events you'll see in a real hospital workup. You start broad with your routine labs and scans in step 1. Use biomarkers to rule out certain conditions in step 2. You visualize the heart's structure and function in step 3. And then, if you still need more data to make those massive therapeutic decisions, you escalate to invasive diagnostics in step 4.
All right, Section 1, Initial Routine Evaluation, Setting the Baseline.
When a patient first rolls through those hospital doors presenting with those classic signs and symptoms, it is time for some rapid-fire ward pimping. What routine labs are you going to order? Well, you're going to want a comprehensive metabolic panel, a complete blood count, and a urinalysis. Now look closely at that CMP. Why do we even care if the blood urea, nitrogen, and creatinine are elevated? It tells us there's reduced renal blood flow or increased venous pressure, which is a classic hallmark of cardiorenal syndrome. Next question, why do we look so closely at their sodium levels? I'll tell you why. Hyponatremia is a critical prognostic indicator. If your patient has hyponatremia, it actually predicts decreased long-term survival. That is a massive, high-yield concept for your exams and, more importantly, for your patient care.
Next up in your routine evaluation is the electrocardiogram. And while there is no single specific ECG pattern that absolutely confirms heart failure, you cannot skip this step. Why? Because you are hunting for arrhythmias. In fact, a staggering 40% of heart failure patients have atrial fibrillation. You also need to scan that ECG for high-yield buzzwords like Q waves, which give you hard evidence of a prior myocardial infarction, or conduction issues like a left bundle branch block, your classic LBB.
And this brilliantly illustrates our final part of the initial baseline, the chest X-ray. What exactly are you looking for here? Well, you want to detect cardiomegaly, which is a cardiothoracic ratio greater than 0.5, and you really want to look for pulmonary venous congestion. The absolute key buzzword here is curly B lines. But just as importantly, the chest X-ray helps you rapidly differentiate heart failure from non-cardiac causes of all that shortness of breath, things like pneumonia or COPD.
Moving right along to Section 2, Biomarkers in Heart Failure, the natriuretic peptides. So now we're escalating the workup biochemically, looking specifically at the natriuretic peptides, BMP and NT-proBNP. These peptides are essentially released in response to increased heart wall stress, and they are phenomenal diagnostic tools. Seriously, I want you to burn this next concept into your memory to save yourself on rounds: negative predictive value. If a patient comes in with acute dyspnea and their BMP or NT-proBNP level is low, that test has a very high negative predictive value. That means a low level effectively excludes heart failure as the culprit for their shortness of breath.
But let's say the levels are elevated. It is super important to understand how these biomarkers differ across clinical phenotypes. Generally speaking, if you compare heart failure with reduced ejection fraction, or HFrEF, to heart failure with preserved ejection fraction, or HFpF, you're going to see a distinct difference. Patients with HFrEF generally present with higher natriuretic peptide levels, while those with HFpF generally have lower levels in comparison.
Now, what's really interesting about this is how patient-specific confounding factors must adjust our clinical thresholds. You literally cannot just look at a raw number. You have to look at the whole patient in front of you. Things like older age, female sex, and chronic kidney disease can elevate these peptides entirely independent of heart failure. On the flip side, obesity can actually falsely lower these biomarker levels. So absolutely keep those confounders in mind when you're interpreting your labs.
Section 3, Non-Invasive Cardiac Imaging, Seeing the Heart.
All right, we've looked at the labs, we've analyzed the biomarkers, now it's time to actually see the heart's structure and function. The absolute gold standard, the most essential non-invasive test you can possibly order is two-dimensional echocardiography with Doppler. This gives you a rapid bedside assessment of critical metrics. You get the left ventricular ejection fraction, your LVEF, you get the ventricular volumes, you get a real-time look at valvular function. It also lets you estimate pulmonary artery pressures and detect diastolic filling abnormalities, which, by the way, is incredibly important for diagnosing HFpF.
If the echo leaves you with some unanswered questions, you might turn to cardiac magnetic resonance, or CMR. CMR is highly accurate for quantifying ventricular mass and volumes, but its absolute superpower is tissue characterization. When you hear the phrase tissue characterization, I want you to immediately think of CMR. This is exactly how you identify specific, tricky underlying causes like myocardial scarring from a prior MI or infiltrative diseases such as sarcoidosis or amyloidosis. Rounding out our non-invasive options, we have cardiac CT and PET scans. So, when do you use which? Well, you use a cardiac CT when you need to rule out obstructive coronary artery disease or pericardial disease. On the other hand, you'd use a PET scan when you really need to evaluate for myocardial ischemia or active inflammation, which is particularly useful in cases of suspected cardiac sarcoidosis.
Let's move to Section 4, Specialized and Invasive Testing, Advanced Diagnostics.
Let's see how this builds into our final, most advanced tier of the algorithm. This is where we go when the diagnosis is still uncertain or when we're making massive, life-altering therapeutic decisions. First up in this advanced toolkit is cardiopulmonary exercise testing, or CPET. This test provides a highly objective measure of a patient's functional capacity by actually measuring their VO2 max. It's an amazing tool for defining the true cause of dyspnea when things are murky. But more importantly, we use CPET's objective data to help time advanced therapies, like knowing exactly the right moment to list a patient for a heart transplantation.
Now, when you're in the intensive care setting with a critically ill patient, you might use a pulmonary artery catheter for invasive hemodynamics. So the crucial point is that this ICU line allows you to actually measure cardiac output and filling pressures directly. And by doing this, you can definitively differentiate between cardiogenic pulmonary edema, which is our heart failure, and non-cardiogenic pulmonary edema.
Finally, we reach the rarest, most invasive step of them all, the endomyocardial biopsy. Let me be clear, this is absolutely not a routine test. However, it does remain the gold standard for diagnosing a few very specific, severe conditions. The major, flashing lights, high-yield buzzword to associate with this concept is giant cell myocarditis. If you suspect giant cell myocarditis or certain really complex infiltrative diseases, the biopsy is how you secure that diagnosis. And with that, you have successfully navigated the diagnostic algorithm. The diagnosis is secured, the phenotype is established, the etiology is identified, and you have your prognostic information locked in. But here's a thought to leave you with. Now that you know exactly what is wrong with the patient's heart, what is the next step in their care? I mean, how are you actually going to fix it? Well, that brings us into the incredibly exciting world of heart failure therapeutics, which we will definitely have to save for another explainer. Keep this diagnostic framework in mind, trust your algorithm, and best of luck out there on your clinical rotations.